You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about atrioventricular block. We'll go over the diagnosis and definitions of first degree, second degree, third degree AV block and related concepts. We'll talk about reversible etiologies of AV block. Then we'll talk about management of AV block according to the guidelines. Let's start with the diagnosis. First degree AV block is AV block where the PR interval is more than 200 milliseconds, so that is more than one big box on the regular EKG. It does not have dropped beats. Second degree AV block is AV block where not all the P's can pass through the QRS and can be classified as Mobitz type 1 or type 2. In Mobitz type 1, the PR interval keeps on elongating until there is a P wave that fails to have a QRS complex. That's the dropped beat. This is regularly irregular. So remember that. Mobitz type 1, which is Wenckebach, is regularly irregular. In Mobitz type 2, the PR interval is constant until there is a P wave that fails to have a QRS complex. That's the drop beat here. Mobitz type 2 is irregular, but it is not regularly irregular the way Mobitz type 1 is. Note that in Mobitz type 2, the PR interval is actually normal. It's less than 200 milliseconds, so that's another clue. Mobitz type 2 is a block that occurs below the AV node at the His bundle, unlike Mobitz type 1, which is a block within the AV node. And how about third degree AV block? That's when you have complete dissociation. The atria generates P waves at 60 to 100 beats per minute, while the ventricle generates QRS complexes at 20 to 40 beats per minute, marching by themselves. If the ventricular impulse comes from the His bundle, the QRS width will be normal within 120 milliseconds. If the ventricular impulse comes from the Purkinje system, the QRS width will be wide, more than 120 milliseconds. So recall that PR interval is prolonged in first degree AV block, elongating in second degree Mobitz type 1, normal in second degree Mobitz type 2, and not applicable in third degree AV block. Beats are dropped only in second degree AV blocks, whereas beats are never dropped in first degree AV block and not really dropped in third degree AV block, although you can't exactly say that since none of the QRS follows the P's in third degree AV block. I don't know if any of you guys have heard of the heart block poem, but I think it's pretty neat. So the heart block poem goes as follows. If the R is far from the P, then you have a first degree. If the PR gets longer, drop. It's a case of Wenckebach. If some R's don't come through, prepare to pace that Mobitz II. If the P's and Q's don't agree, you gotta pace that third degree. That's a heart block poem, okay? Hope that helps. When you see 2-to-1 conduction in complete heart block, if the PR interval of the conducted beat is less than 160 milliseconds, it's infranodal block. If the PR interval of the conducted beat is more than 160 milliseconds, it's intranodal block. The PR interval is made up of the AH interval and the HV interval. The AH interval, which is normally 60 to 120 milliseconds, is the time it goes from the atrium to the His. The HV interval, which is normally 35 to 55 milliseconds, is the time it goes from the His to the ventricle. The AH interval can be stretched, but the HV interval cannot be stretched. So if the PR interval is prolonged, it is because of AH prolongation. The AH and HV interval can't be measured on standard EKG on the surface. It has to be measured by EP study. The HV interval more than 55 milliseconds suggests organic heart disease, a greater likelihood of developing trifascicular block, and higher mortality. If HV interval is more than 55 milliseconds, there is a class 1 recommendation for placing a dual chamber pacemaker. The sinus node recovery time, or SNRT, is determined by applying overdrive pacing to suppress the sinus node. It is measured by subtracting the spontaneous sinus node cycle length before pacing from one time delay to the first spontaneous sinus response after termination of pacing. Normal sinus node recovery time is less than 525 milliseconds. Prolonged sinus node recovery time suggests abnormal sinus node function. Because many patients with impaired sinus node function also have abnormal AV conduction, EP study should also evaluate AV nodal and His Purkinje function in this population. If it's intranodal block, you should see conduction improve when the patient is walking around or angry. If it gets worse instead, then it's infranodal block. Infranodal block will not respond to atropine. Infranodal block doesn't care what your sympathetic tone is. Speaking of intranodal block, another thing that you can do if the patient is stuck in bed and they can't walk around is to have them do exercises within the bed. You can have them clap, you can have them do rotating arm movements, anything that gets them to exercise. And you can see if the AV block gets worse, then you know that is actually infranodal block rather than intranodal block. Stokes-Adams attack is a phenomenon when a third-degree AV block has at least 4 seconds without ventricular depolarization, i.e. without QRS complexes, and it causes syncope. So that's just another thing to know. Now let's move on to the section on reversible etiologies. Whenever you have AV block, in addition to diagnosing and treating an AV block, you need to do a thorough search of anything that can be causing the AV block. Causes can include medications, structural and infiltrative disease, infections, increased vagal tone, endocrine disorders, autonomic dysfunction, ischemia, electrolyte imbalances, and postoperative state. So let's go through these one by one. Medications. We all know beta blockers such as metoprolol, atenolol can decrease AV conduction, as can calcium channel blockers, especially the non-dihydropyridine ones such as verapamil and diltiazem, since these slow conduction through the AV node. In terms of antiarrhythmics, class 1C and class 3 you have to watch out for. Flecainide and propafenone, these sodium channel blockers slow conduction through the atria, AV node, and ventricles. Amiodarone and dronedarone prolong AV conduction, and sotalol even more so because it also has intrinsic beta blocker activity. Digoxin can increase vagal tone, leading to slower AV node conduction. Adenosine, which is used in supraventricular tachycardia acutely, will temporarily block the AV node, but that one you know because you'd be the one giving it. Funny current inhibitors such as ivabradine that can be used in certain patients with heart failure or inappropriate sinus tachycardia, that primarily affects the sinus node, but it can also lead to AV block. Tricyclic antidepressants such as amitriptyline or imipramine and SSRIs such as citalopram or escitalopram are usually associated with QT prolongation but can also have AV block. Antipsychotics such as chlorpromazine and thioridazine can cause AV block due to their anticholinergic and quinidine-like effects on the myocardium. Opioids such as methadone at higher doses can cause bradycardia and AV block due to their effects on the autonomic nervous system. Chemotherapy, such as 5-fluorouracil, capecitabine, and ibrutinib, which is a Bruton's tyrosine kinase inhibitor, can cause conduction disturbances, including AV block. Antibiotics, macrolides such as erythromycin or fluoroquinolones such as levofloxacin and moxifloxacin, can prolong QT interval and also cause AV block. In terms of structural and infiltrative disease, reversible myocarditis or sarcoidosis in its early stages may cause transient AV block. In terms of infections, the one that everyone knows about is Lyme disease. Lyme disease can cause Lyme carditis, which may manifest as AV block that's typically reversible with antibiotic treatment. So when you get a patient with Lyme disease, don't be in a rush to insert a pacemaker in these individuals because in almost all cases with subsequent antibiotics, the AV block will resolve. Viral myocarditis is inflammation of the myocardium, and this can involve the conduction system as well. In terms of increased vagal tone, this is a very common one, especially in the hospital. Vagal stimulation due to pain, sleep apnea, or during maneuvers such as suctioning in a ventilated patient or endoscopy, these can all cause transient AV block. For more information about increased vagal tone and vasovagal syncope, please refer to the syncope episode 2 episodes prior. In terms of endocrine disorders, hypothyroidism can slow the heart rate and impair AV conduction, and adrenal insufficiency, as in Addison's disease, can contribute to hypotension and conduction abnormalities. Autonomic dysfunction, neurocardiogenic syncope or vasovagal episodes, as I mentioned, can lead to bradycardia and AV block due to excessive parasympathetic activation. Then you have ischemia, myocardial ischemia, especially inferior MI, involving the right coronary artery, which supplies blood to the AV node, can cause transient AV block. Coronary ischemia, transient or reversible due to blood flow restoration, such as through PCI thrombolysis, can also cause that. Electrolyte imbalances such as hyper or hypokalemia, calcemia, and magnesemia can also lead to AV block. And then post-operative state, post-cardiac surgery, particular valve surgery or surgeries involving the septum of the heart or the AV node can cause temporary AV block. An important one to know is transcatheter interventions such as TAVR, transcatheter aortic valve replacement, will have a high rate of causing AV block that may be temporary or permanent. Now that we've talked about the reversible etiologies, we can move on to the management. An exercise treadmill stress test can help differentiate whether you have Mobitz type 1 or type 2 AV block when you encounter a situation of exact 2-to-1 AV block. Because when you have exact 2-to-1 AV block, you don't have the opportunity to see whether you have a increasingly prolonged PR interval before a drop, or if you have fixed PR intervals before a drop. So you can exercise the patient. In fact, if you wanted to do a poor man's version of this, you can have the patient just exercise in bed or walk around the room. But more formally, you can do a treadmill stress test. Exercise causes withdrawal of vagal tone and increased sympathetic tone, leading to improved atrioventricular nodal conduction. If the baseline atrioventricular block is infranodal, that's Mobitz type 2, the atrioventricular block will not resolve and will likely worsen as the sinus rate increases. If the latter ensues, then a pacemaker would be indicated. If the atrioventricular block is Mobitz type 1, then increased sympathetic tone will facilitate conduction through the AV node and may lead to resolution of the AV block. Therefore, the 2018 ACC/AHA HRS guidelines on bradycardia and AV block say that in patients with exertional symptoms such as chest pain or shortness of breath who have first degree or second degree Mobitz type 1 atrioventricular block at rest, an exercise treadmill test is reasonable to determine whether they may benefit from permanent pacing. That is a class 2A recommendation. In a patient with AV nodal block, carotid sinus massage will slow the sinus rate and worsen AV conduction, which will worsen the AV block. The slowing of the sinus rate and depression of AV conduction will have a protective effect on the distal conduction system, so conduction in the His-Purkinje system may improve. More broadly, the 2018 bradycardia and AV block guidelines say, in selected patients with second-degree atrioventricular block, carotid sinus massage and/or pharmacologic challenge with atropine, isoproterenol, or procainamide may be considered to determine the level of block and to determine whether they may benefit from permanent pacing, Class 2B. The 2018 bradycardia and AV block guidelines say, in patients with first-degree atrioventricular block or second-degree Mobitz type 1, which is Wenckebach, or 2-to-1 atrioventricular block, which is believed to be at the level of the atrioventricular node, with symptoms that do not temporarily correspond to the atrioventricular block, permanent pacing should not be performed. That's a Class 3 indication, harm. In asymptomatic patients with first-degree atrioventricular block or second-degree Mobitz type 1 block, Wenckebach, or 2-to-1 atrioventricular block, which is believed to be at a level of the atrioventricular node, permanent pacing should not be performed, Class 3, harm. Although pacemakers do not improve survival in patients with isolated first-degree AV block, it is now recognized that marked first-degree AV block, meaning a PR interval more than 300 milliseconds, can lead to symptoms even in the absence of higher degrees of AV block. And recall that PR interval is supposed to be less than 200 milliseconds. So marked first-degree AV block here is defined as PR interval more than 300 milliseconds. When marked first-degree AV block for any reason causes atrial systole in close proximity to the preceding ventricular systole and produces hemodynamic consequences usually associated with retrograde, i.e. ventricular atrial conduction, including Cannon A waves, then you may see signs and symptoms similar to pacemaker syndrome. With marked first-degree AV block, atrial contraction occurs before complete atrial filling, so ventricular filling is compromised, and an increase in pulmonary capillary wedge pressure and a decrease in cardiac output will follow. Small uncontrolled trials have suggested some symptomatic and functional improvement by pacing up patients with PR intervals more than 300 milliseconds by decreasing the time for AV conduction. The 2018 bradycardia and AV block guidelines give some allowance. In patients with marked first-degree or second-degree Mobitz type 1, Wenckebach, atrioventricular block with symptoms that are clearly attributable to the atrioventricular block, permanent pacing is reasonable, Class 2A. So they do have some leeway for that. Among CCU patients with second-degree AV block, 90% of the cases are Mobitz type 1, that's swanky back, and 10% of the cases are Mobitz type 2. So 90% of the time you're dealing with this intranodal block, not an infranodal block. So, that is relatively reassuring. The 2018 bradycardia and AV block guidelines say, in patients with symptoms, i.e. lightheadedness or dizziness of unclear etiology who have first-degree atrioventricular block or second-degree Mobitz type 1 atrioventricular block on ECG, ambulatory electrocardiographic monitoring is reasonable to establish correlation between symptoms and rhythm abnormalities. That's a Class 2A recommendation. And if you want to learn more about ambulatory electrocardiographic monitoring devices, just listen to the syncope episode 2 episodes prior. AV dissociation can occur in accelerated atrioventricular rhythm, or AIVR, or complete heart block. The two can be distinguished by the atrial and ventricular rates. In complete heart block, the sinus rate is faster than the ventricular rate. In AIVR, the ventricular rate is faster than the sinus rate. In first-degree heart block, the delay in ventricular conduction after atrial contraction gives the leaflets of the mitral and tricuspid valves time to drift toward a partially closed position prior to ventricular systole, so the intensity of the first heart sound is diminished as there is not much distance left for the mitral and tricuspid valves to traverse until closure. The situations to place a pacemaker in AV block are as follows. In patients with acquired second-degree Mobitz type 2 atrioventricular block, high-grade atrioventricular block, or third-degree atrioventricular block not attributable to reversible or physiologic causes, permanent pacing is recommended regardless of symptoms. That's a Class 1 recommendation from the 2018 guidelines. In patients who develop symptomatic atrioventricular block as a consequence of guideline-directed medical therapy, for which there is no alternative treatment and continued treatment is clinically necessary, permanent pacing is recommended to increase heart rate and improve symptoms. Class 1. This particular guideline recommendation is referring to heart failure patients who you need to put GDMT, and if the GDMT necessitates that you need to do permanent pacing, or if permanent pacing will facilitate up titration and addition of GDMT, then it is reasonable to do. Then, in patients with an infiltrative cardiomyopathy, such as cardiac sarcoidosis or amyloidosis, and second-degree Mobitz type 2 atrioventricular block, high-grade atrioventricular block, or third-degree atrioventricular block, permanent pacing with additional defibrillator capacity if needed, and meaningful survival of greater than 1 year is expected, is reasonable. That's a very run-on sentence that they have there, but anyway, that's a Class 2A indication from the 2018 guidelines. So we have talked about AV block diagnosis and definitions, reversible etiologies, and management. That's all for AV block.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.